Thank you, Chris. It's really great to be here, a little different than usual, but really great to be here. And I want to introduce our fantastic panel today. I want to start with Troy Brennan, who is the Executive Vice President and Chief Medical Officer for CVS Health. Troy, welcome. We have David Brown, who's the Chair of the Department of Emergency Medicine at Massachusetts General Hospital and the MGH Trustees Professor of Emergency Medicine at Harvard Medical School. David, always great to get together with you, even virtually. We have Julie Lankiewicz, who's the Head of Clinical Affairs and Health Economics Outcomes Research in Bose Health. And also Michael Van Rooyen, a longtime friend and associate of mine, Chair of Emergency Medicine at Brigham Health, the J. Stephen Bowen Professor of Emergency Medicine at Harvard Medical School, and the Levine Family Professor of Humanitarian Studies at the Harvard T.H. Chan School of Public Health. So we have a really fantastic panel and not a lot of time, so I'm going to jump right into it. And Troy, I'm going to ask you the first question. What have you learned about the capabilities and limitations of convenience care sites, such as your CVS Minute Clinics, in light of COVID-19?
Well, clearly, the problem is that there's a good deal of reticence about people seeking care at a place that's a walk-in clinic. I think you've seen it across the board in retail health and urgent care. So our visits are down probably about 70%, something that's relatively similar, I think, to the rest of ambulatory care. And so as a result, we have people in ambulatory care. We've pivoted to telemedicine. That's making up about 2/3 of our visits at this point. And we have to begin to sort of rethink what we're going to look like in the fall. We're tending to believe that there's going to be sort of continuing cooling off of the pandemic through much of the summer, but have to be prepared for a return in the early part of the fall. And by then, we want to be able to be set to be able to do COVID testing at our retail pharmacies, and then to be able to address the usual problems that we see a lot of during that period of time, which is flu and upper respiratory tract infection. So it takes a combination of a digital front end, a safe place for people to be tested using point of care technology, and then the ability to care for those face-to-face who are not infected with COVID and those who are infected with COVID, to make sure that we get them quarantined as quickly as possible.
Troy, unfortunately, we've dropped audio here, but I see you're not talking anymore, so you can just nod your head and let me know you're finished. Thank you. I understand everyone else is hearing okay, we're just not hearing each other. So my next question, David, is for you. And Mike, you can listen in as well, because I'm going to follow up with the exact same question for you in just a moment. What are the one or two key workflow changes or innovations that you developed for COVID-19 that you see carrying forward into your future operations? David?
Well, it's a great question, Ron. And some of the innovations we didn't actually develop, but I anticipate will carry on, and that's what I like to call PPE forever. I can't imagine a future state where we won't need easy access to comfortable PPE, because COVID-19 will be with us for quite some time, and we live in a different world because of that. In terms of specific innovations to try to reduce risk, we've tried to harness technology and use some of the telehealth principles in the emergency department. That doesn't always translate. You wouldn't think that a specialty that's primarily delivered at the bedside would be able to use teletechnology, but in fact we've been able to use it even inside the ED to reduce the patient-doctor physical contact, which both improves safety but also reduces the demand for PPE. And I think that that will continue. So rigging rooms with iPads or something like that and communicating with the patient through the door, a visible door through much of the visit, is a technology and an innovation that will continue on. And then the last thing I'd say is that decreasing ED utilization through a variety of innovations, including tele-emergency medicine techniques, not just inside the ED, but outwardly to patients, tele-urgent care, but also harnessing mobile integrated health tools, using primarily paramedics and EMS providers, and the transportation, their ambulance rigs, which are generally available. and using those providers in the field either to prevent ED visits or to prevent ED revisits or to prevent revisits that result in hospital admission. And they can be used in all three populations, and I think that will extend well beyond the pandemic.
Great, thank you, David. And Mike, I'll just quickly repeat the question for you. Just one or two key workflow changes or innovations that you've developed during COVID-19 that you see carrying forward into the future.
Hi, thank you, Ron, and pleasure to be here with the panel. In addition to, as David mentioned, the adaptation of telemedical support in the emergency department to help communicate with providers, can communicate through and across rooms, we've adapted a number of I think novel technologies to sort of separate patients who may be COVID positive from those who are likely to be COVID negative before we can test in order to screen. We used a variety of forms of telemedicine, including a robotic dog, for example, that had an iPad as a face that would help us interview patients, and some adaptations like that. Although I'm not sure that will carry into the next era, it was actually really useful to be able to separate patient from provider and allow us to still have an interaction without using excess PPE. Another innovation that we found useful was in patients that pose a specific infectious threat, like COVID, for example. We developed an intubation hood that allowed us to have essentially a tent that placed over the top half of the body, that if we were doing an aerosolizing procedure in a patient that was high risk for an aerosolized infection like COVID, it protected the providers and gave them an additional layer of protection while being able to manipulate the airway within the hood. That's been useful, and I think as we see infectious threats in the future, we will be able to employ that and kind of refine that device. And finally, I'll say that I'll agree with David that much of the innovation is around just managing emergency health outside of the emergency department, managing the network and mobilizing the power of mobile integrated health, home hospital, and other ways to sort of keep patients at home rather than coming into the emergency department. And I think we'll see that carry forward.
Mike, thank you. And I did have the opportunity to see the intubation hood in use, and the fact that it was made out of some very inexpensive PVC components and just a standard equipment cover, really amazing. I mean, anyone could put that together and use it. So I think that's a really good example. Julie, we're going to move on to you now. Where have you seen a technology impact through your lens during this COVID-19 response, and how do you see applying this in the future?
Thanks, Ron. Pleasure to be here. Echoing on the sentiments shared by the others, I think technology impacts right now are just strictly and not aligned to enabling a more robust culture of safety across the continuum of care, outside the hospital to urgent care and convenience care as well. I think there's probably two pragmatic examples of where we're seeing increases in that care, one being around management of the care environment itself, and another around general wellness and population management. So in the care environment regard, we're seeing technologies that have historically been relegated to decontaminating ORs in between cases, and those rooms having contact precaution isolation patients that are colonized with C. diff, MRSA, and the like. And when I say technologies, I'm talking about things like UV, robots, smart technology, and taking these types of technologies and deploying them outside of those environments to areas where they typically wouldn't have been. I think this is really important, especially as we become more prudent about the use of antimicrobial agents, since we definitely don't want to engender any more resistance to these virulent strains of COVID and other things that we're seeing. So that's one aspect. In addition to those items that touch patients every day, pulse ox, EKG, cable and lead wire systems, these are historically wiped down very quickly between patients, and now that just isn't adequate. So sending those off to FDA-approved reprocessing sites so that they can reintegrate into the continuum of care in a non-threatening way. Transitioning from that mitigation of risk to from the environment of care, more to mitigation of risk from a wellness perspective, Express Scripts just came out with a staggering statistic that during the week of March 15th, 78% of prescriptions for anxiety, depression, and insomnia were brand new prescriptions. So that really highlights the need across society for an enhanced look at that space. And that's, I think, where digital therapeutics can really come to play. Also, we know that clinician burnout, in addition to the gen pop wellness, is risky to begin with, and the COVID pandemic has unfortunately exacerbated that. So whenever we can look for digital technology solutions to either augment or replace certain types of prescription medications that may have black box warnings, like many of the prescription sleep medicines that we're seeing, that's another opportunity for care across the continuum. We're right now exploring some really novel ways to provide safe, effective, non-pharmacological, audio-driven content to clinicians and the general population to promote relaxation, protect sleep, and ensure that when they return to the workplace, that their mental acuity is at the proper level to ensure patient safety.
That's great, Julie. Thank you very much. Troy, we're going to jump back to you now, and this is a little bit about looking forward as our societies contemplate opening up, and you have a very large number of care delivery sites. What do you see as the future of testing for COVID-19? Whose responsibility is it, and how do you see it playing out?
Well, I kind of see the market flourishing here. There's a lot of new technologies that are being used and a lot of opportunities. I'd say there's going to continue to be testing that will be done by large labs, centralized labs, both run by large hospital systems as well as LabCorp and Quest. I think some of that will move to the home. There's already a couple of tests that are approved for using either a swab or saliva from the home. The first of the so-called antigen tests was approved at the end of last week. And I think that those machines will provide point-of-care technology that will enable people to get sort of on-demand testing. And I see all that sort of coming to replace much of what's going on in tent sites. We're a good example. We run 6 major tent sites right now. We're doing about 6,000 tests a day, but we'll be moving much of what's going on in those tent sites to our stores. We're planning by the end of the month to have 1,000 stores with drive-up capability that'll be able to do 60 or 70 tests per day. So really strong contribution to the overall testing capacity. And then I think we'll move increasingly to a point of care approach over the course of the early fall and get ready for what we hope will not be too bad of a return of this coronavirus during the fall flu season. But I think that we will be rapidly gearing up testing, and I think that'll go hand in hand with new technology around contact tracing, both of which are going to help enable faster opening of society.
Great, Troy, thank you. And Mike, we're going to reverse your order and David's for this one, and I'm going to flip this straight over to you. From the emergency medicine perspective, what are you seeing as the future of testing, and whose responsibility is it, and how do you think it'll play out over the next, say, 6 months or so, or to a year?
Well, thank you. And it's great to hear Troy's vision for testing, because to have that brought into the community is so important. I think the emergency department will have to play still an important role in testing, because we, again, are the receiver of patients and the safety net for the community. And so we'll have to have rapid testing to distribute patients appropriately. So the future of testing in emergency medicine is to make sure that we have fluent testing and rapid testing available so that we can determine where to place patients through a system. I think the new normal for us in the future is going to be distributed care and probably a lot more telehealth, but still sick patients and critically ill patients, the right patients that present to the emergency department, will have to be rapidly tested and then those issues addressed on the fly.
Great, thank you. David, additional perspectives on testing from the emergency department perspective?
Well, sure. I guess I agree with what Mike said, and since nobody wanted to ask answer who's responsible for it, maybe I could try that. I think we're going to need much more scaled up testing capability as we reopen society. Between the hospitals and the private sector right now, we're still only able to do in the thousands per day, and we clearly need to be able to do more than that. So, and I think that a program of that size would generally be administered by a governmental agency. It could be, of course, delegated or administered by the private sector, and that may make sense, but this is a societal need, and so I would view it as a government responsibility. I'm curious what the other panelists think about that. And then I expect that we will see more disease as society reopens. That's to be expected. I think it's going to come sooner than the fall, even if we all wear masks and practice good distancing. As we come closer together, we will have more resurgence of some disease, and the key is to keep the peak of that disease below the threshold for which the critical illness among it can be cared for in our local hospitals. And then the final thing I'll say about testing is that we are hamstrung at the point of care in the emergency department by the relatively low sensitivity of the test. Our patients are high probability, they have symptoms, and the negative test in that population is hard to rely on. That's different when you're testing a low risk or an asymptomatic population, but it's a big need for those of us taking care of ill patients.
Great, thank you. I would say three distinctly different but very complementary views of testing. I'm going to switch gears again now, and Julie, we'll start with you this time. What is the single biggest change that you see in your area from now sort of to the point where we have sufficient herd immunity to think that COVID is just behind us or is just a baseline disease? What's the single biggest change you're seeing?
Right, I think the COVID pandemic has essentially served as a catalyst for many digital therapeutics and software as a medical device opportunities. Just last month, the FDA put out about 16 different guidance documents to look for ways for patients to have more autonomy over their care in partnership with their clinicians, reducing the burden on those emergency department visits for certain conditions that perhaps have gone awry. And I think that certain application of digital therapeutic and or software as medical device could really help mitigate those risks and the burden on the healthcare system, as well as exposure to patients who really shouldn't be entering those types of environments.
So you see digital transformation. Mike, what do you see?
I see digital transformation, as Julie mentioned, coupled with the recognition in society that distribution into other care settings is more appropriate for certain low-risk diseases and conditions. So, the use of telemedicine, the use of mobile integrated health, the use of home hospital, the distribution of patients that's appropriate for the level of care they need will allow emergency departments to do what they do best. So I think that system change, coupled with the connection with technology, will create a bit of a different system, and we'll have to adapt to that new system in the way that we care for patients in a broader network.
Great. And Troy, same question to you. What's the single biggest change you're seeing or you anticipate?
Well, I anticipate a much stronger focus on social determinants of health. And certainly a lot of discussion about that over the course of the last couple of years, but especially as we begin to see the way in which this pandemic is falling so hard on people of color and people who are impoverished and people who have more comorbidities. I think it's going to open our eyes even more so than we have had in the past to the need to be thinking about the ways in which social determinants of health should be playing into the way in which we elaborate care. Testing is a great example. We need to have more testing, more broadly dispersed in society so that everyone can take advantage of it. Or we're going to continue to have the same discrepancies in rates of disease that we're seeing right now. So I'm hoping that one of the benefits of this is that it opens up people's eyes to the need to really address social determinants of health.
I think that's a topic for a whole panel too, Troy. Thank you. David, I'm going to give you the last word. We have about a minute or so left. What do you see as the biggest change that you're anticipating in your realm?
Well, I agree with the comments made by the three panelists, and so I'll add a fourth thought to this, and that is that we've seen essential cratering of demand for care in the low acuity settings of urgent care and in emergency departments. There's been massive reductions in ED and urgent care visits. And since a lot of that care is delivered at, I would say, consumer demand rather than being clearly, let's say, distinctly medically necessary, it'll be interesting to see as we come out of the pandemic how much of that demand for the convenience of urgent care still exists. I think that as it relates to the emergency department, we will have to rethink and restructure and restaff ourselves as what is likely to be a lower volume, higher acuity site of care.
Great. Thank you very much, David. I'd like to just take this moment now to thank all of our panelists for really insightful and very well-formed and well-stated opinions on a very controversial and difficult topic. So thank you all for your time. And Chris, I'll pass it back to you.